Southend is very different from other compound pharmacies because we have one thing that a lot of companies don't. We focus our entire model on you.
Oh, it's in here? Oh.
Everything we do here, this new facility that we put into play, is all related to being able to get you the care that you need faster. I don't think anybody out there can do it as good as we do. When providers reach out to us with any question, they're clinical or not, our team of pharmacists are here to help them. And we listen. They're able to pick up the phone, call us. Humans, at the end of the day, are able to pick up and talk to them. I see Southend headed to be the leading compound pharmacy in all of America.
Welcome, and thank you for joining Southend Pharmacy for our educational webinar today. I'm Haley Calavo, our VP of Marketing here at Southend Pharmacy, and looking forward to kicking this off with you. A fun fact, why you get to hear from me today, I've actually spent the last 15 years in 503A pharmacy, and admittedly and unapologetically, one of my favorite aspects of this job is delivering marketing education for providers that creates meaningful access and innovation in patient care. And I think a lot of that impact is what drives all of us every day. A little bit of housekeeping items. First, we'll start with a disclaimer and check that box for my compliance team. First off, the content here is provided for educational and informational purposes only and does not constitute legal advice. And attendance or receipt of these materials does not create an attorney-client relationship. Secondly, compounded medications are not reviewed or verified for the FDA for safety, effectiveness, or quality and are not FDA approved. Last comment is actually surrounding Q&A. You should have a little button at the bottom of your screen. You may have to hit the little 3 buttons with the more circle to find it, but there is a little button that says Q&A. We would love to hear from you today. If you have questions for Jim Live, we would love to be able to answer those at the end of the presentation for you. Before we get into today's conversation, I just want to give you a little context to who Southend is and what drives us to do the work we do every day. So essentially, our mission is centered around delivering care and meaningful support to every patient and provider we serve. And as we've grown, we've remained incredibly focused on clinical excellence and earning the trust of both patients and providers. And so our vision really comes down to one belief that precision and science and humanity and care belong together. And so that philosophy has really shaped the pharmacy we're building today. We don't simply want to fill prescriptions. We want to continue raising the standard of what providers should expect out of their compound partner. And so to truly put that mission into practice, Southend is a 503A compound pharmacy, which means we prepare medications for individual patients based on prescriptions from licensed providers. That patient-centric model is at the center of what we do. Each medication prepared with clinical rigor and precision. And today, Southend actually operates across 39 plus active states, allowing us to support providers and their patients nationwide, and we're continually expanding. So a huge shout out to our compliance team doing the real work to get us to this point. And as our footprint has grown, our focus has remained the same, patient-centric care, precision in every prescription, and being that dependable partner to the providers we serve. When we talk about the Southend standard, we're really talking about these principles that guide how we practice every day. And these 4 pillars, starting with compliance, this is foundational for us here at Southend. And so this isn't something we add to the process after the fact. It informs how we operate, how we make decisions, and support our providers and patients. Clinical expertise is equally important. Our pharmacists aren't simply behind the scenes preparing prescriptions. They are an important part of the partnership and the resources we provide to providers and how we serve them. Quality is also throughout every process, from preparations to testing and fulfillment. We believe speed matters, but built in with automations and never at the expense of quality or compliance. Those four pillars work together, and as the compound landscape continues to evolve, our commitment is to raising that standard and helping providers navigate it. Lastly, these are a few of our specific product lines that are central to our offerings here at Southend Pharmacy, focusing on all of their unique applications and your patient's outcomes. So our upcoming product offerings will further expand longevity, hormone replacement therapy, sexual health, and ensuring we can support a comprehensive approach to well-being for all patients. Southend Pharmacy is waiting with bated breath for FDA support and adding peptides for Category 1 bulks list inclusion for 503A compounding, so we may further drive innovation and care through product line expansions into peptide formulas. Now it is my pleasure to introduce our speaker today, James LaValle, also known as Jim. Jim is an internationally recognized clinical pharmacist, board-certified clinical nutritionist, educator, author of more than 26 books. He brings more than 40 years of clinical experience spanning natural products, lifestyle medicine, drug nutrient depletion, compound pharmacy, and peptides. What I particularly appreciate about Jim is despite everything he's accomplished, he's still actively seeing patients or clients. So what you'll hear from him today simply is not just academic. He brings decades of real-world experience, practical application from working with thousands of patients throughout his career. Jim also serves as the co-chair of A4M. He serves on the board of the Peptide Society, has spent decades in academia. His contributions to the field have earned him numerous honors, including Clinician of the Year, A4M Educator of the Year, and one of the 50 most influential pharmacists. He's also the founder of the Metabolic Code Enterprises and currently serves as the Chief Science Officer at Lifetime. Given how quickly the peptide landscape is evolving, I can't think of anyone better to help us separate science from the noise and bring practical clinical perspective to this conversation. Jim, thank you for joining us. I'll turn it over to you.
No, that's great. Thanks. Real pleasure to be here. Obviously, I've had a lot of interest in peptides, being at the PCAT committee and testifying there and being a part of what I think is this change that should be coming. So let's get into it. And I hope you guys have plenty of questions. Obviously, been using peptides for 15 years. The last 3 have been kind of difficult, only being able to utilize agents that were already FDA approved, actually, compounds like sermorelin. So let's get started. So, obviously, I am engaged in peptide education and advocacy. I don't have a manufacturing company for peptides. And then, of course, it's an educational review. This is not a prescribing standard or a product endorsement or a legal opinion. And then reported doses, clearly labeled as investigational examples. I'll just kind of go through what is taught when we're teaching at American Academy of Anti-Aging Medicine, kind of the ranges that we see clinicians are, that I have as educators that are doing the recommendations. So, we've got about a 2-hour program, hopefully a lot of time for questions with quite a few folks on. I'm just hoping that, I can answer everything you guys are concerned about. And obviously this is about peptides, or mechanism of action, where the research is going, what actually is going to be accepted. So things like real world evidence, I want to be able to go through that. And really just hope that I give you guys some insight into where the industry's moving, how you can help your patients if you're a clinician. Obviously, if you're a pharmacist and wanting to guide through the maze of this, you're going to gain some insights as well. But the real context of this will be, what happened at PCAC. So, you know, these are the things that we, want to be able to go over is understand, you know, first of all, what peptides are, salt form or not, routes of administration, evaluate where these applications are, where you may see healthcare providers, leaning into using a peptide for what reason, and then of course the current research and what's happening within human populations. Obviously, this is changing daily. There's so much starting to come out, and then apply approved compounded, and also understanding investigational distinctions, including the PCAC limits, to the evidence informed counseling and patient care that you need to do. So this is kind of the timing. Honestly, I'm just going to go like I normally do, guys. So we'll see how it works out, but I think we're going to have plenty of time for questions. I'm going to try and give us more time for questions because I think we're going to have quite a few, I hope. So the first thing is understanding the regulatory context. So 3 years ago, I went to the FDA PCAC committee. The first 5 peptides were presented to them, and I learned a lot. And what I learned was, one, at the time, previous administration was pretty, I would say, against peptides being available for physicians to prescribe to their patients. And once again, my core belief was, as well as members of the American Academy of Peptide Medicine, is that FDA should get between what a provider wants to do with their patient and what the patient needs from the provider. And as long as there's a safety, profile that's there, things should be able to be compounded. And as long as the benefits and risks are discussed, then it should be a relationship that's sustained between the clinician and the patient. From the FDA's perspective, they really wanted to go into, well, it's not an approved drug. Well, of course, it's not an approved drug because that's why it's going in for a 503A bulk compounding list so that it could be allowed to be utilized by providers who previously, quite honestly, millions of prescriptions we had detailed and shown a very strong record of safety for people that were having peptides prescribed to them by a healthcare provider who has prescribing rights and filled through a pharmacy that is making products for human use. So basically all 5 of those peptides got turned down 3 years ago. And then that was in the light of the total of 19 that got placed on category 2. Excuse me. And so that became the next 3 years of work. And really, they kept talking about real world evidence. And what we really had to get to was, one, can we show what the safety is? And that was kind of a little bit optional, but the biggest is, can you identify the product consistently? Are there lab values that can identify the product? Is there a record of evidence of use? And then is there absence of adverse events? And so that was really the basis for 6 of the substances that got added in the PCAC committee hearing this last month. And I have to say that there were some interesting things that occurred during that time, and I'll kind of lead into those and let you know. But once again, patient-specific purpose, confirm with a valid prescription, identified patient and intended purpose. There's formulation control, verifiable calculations, compatibility before use dating, sterility controls, substance identity, the confirmation of eligibility in its exact form, and then a registration and lot-specific certificate of assay. Now, here's where things went wrong, is that So when they get taken away, and all of us know this now, right? There was an incredible explosion of research use only. And the problem with that is that research use only, as everyone has probably read, has a wide variety. Even though a lot of people jumped on the Reddit bandwagon, and I would encourage you not to do that if you haven't heard already what's going on with Lilly. The issue was that safety came into mind. One, in many of those sample, when you looked at research grade product, there wasn't the active ingredient, or there wasn't adequate active ingredient. So label claim didn't match what was in the bottle. And then there was the issue of lead, mercury, other toxins. The forever chemical issue of trifluoroacetate remaining, which is used in production of many of these. And then there was the presence of endotoxin. So taking the products off of the compounding list 3 years ago just drove an unsafe market. And a lot of that was I think the discussion when we were in the PCAC hearing was, well, look, first of all, here's what's happening. We somehow have to encourage or support patient safety. And then the second piece was FDA was still saying, well, just as was the USP, as was the National Association of Boards of Pharmacy, were saying, why can't these just be INDs, investigational new drugs? Well, there's a lot of problems that were around that. One, that's not the law for the PCAC committee for FDA and getting a compound to be able to go to 503A. And so it was comparing apples to oranges. And secondly, it was unreasonable because many of these, peptides are not patentable. Now, unless you change them and bend them, much like a GLP-1 that has a week-long, time frame to its efficacy, the half-life's long, it's a manufactured compound. Many of these peptides are just identical to the peptides that you make in your body. So those aren't going to be patentable agents. And so it created a lot of misalignment. And then the other thing that happened was on this quality control piece, just if those of you that didn't listen in or see, one of the things that I presented was the BPC monograph that the FDA gave the PCAC committee members, because basically we'd given a bunch of information to the FDA, and even though they had gotten it, they had not been able to get it to the PCAC committee members. So what happened was they were looking at research use only certificates of assay that were deficient of safety testing. Instead, we supplied for human use certificates of assay, which showed the testing for metals, testing for endotoxin, testing for trifluoroacetate, testing for the active compound. And in addition to that, being able to identify the accurate molecular weight, how it can be identified, what the peaks were, whether it was under, HPLC or other identification techniques, that these were clearly able to identify the compound. They kept kind of the argument was, well, are you using the acetate or using the free base? All of that was actually explained. And so there were 6 compounds that made it. BPC 157, excuse me, KPV, TV500, MOT-SC, Epitalin, and CMAX. And remember, because of it, and there was a lot of, I would say, I think at the beginning of this, just to give you guys a little bit of understanding, there was a lot of, criticism of the PCAC members that were appointed because, they use peptides in their practice. Well, I thought that was a leg up, that there's somehow a conflict. And yet we never really discussed the conflict FDA may have in terms of, the role Big Pharma has in, funding or people that are, working with FDA. So first create the level that playing field. I think that people on the PCAC committee generally wanted to, give the right vote. They asked very poignant questions to the FDA, and I think it ended up with a great outcome. And just to kind of, before we just jump into these peptides, just to let you know, at the end of it all, I personally felt, I was there the whole week and, working with the legal team there was a coming together that happened. There was a lot of respect that the PCAC members gained with the FDA because they were all clinicians, and they're all, were very well trained clinicians. So I think that really, I'm looking for more and more of that kind of positive energy moving forward as we go into the February committee. So I felt like I had to give you a little bit of background on what was going on. There was a real kinetic energy that was there, that was, I think, truly historic to get, 6 compounds at least recommended to be on bulk. So remember, this does not mean these are approved. This means that they are recommended to the FDA, by the committee to be approved. So we're still waiting for that. On the amylotide, or otherwise DSIP, delta sleep inducing peptide, vote margin was narrow. I think there just wasn't enough evidence that was presented, and so it could come up again. But once again, the FDA staff had previously, proposed being against inclusion of any of these substances. So I think that was really a positive that came out of it. And so, first, just so you understand that regulatory pathway forward, where are we right now? So we had a nomination. We presented, and I'll talk about what we presented on each of the other peptides. FDA reviewed identity, quality, history, efficacy, and safety. The information that they had previously provided the PCAC committee was old information. They didn't get them the new information. So we got the new information to the committee in time, which allowed them to, vote appropriately. And then, of course, there's the rulemaking, proposed rule, comments, final action on this. And then that creates the implementation that it's eligible only after that final pathway is allowed. So current position right now, FDA, Department of Health and Human Services action and rulemaking is pending. I would say that the current administration, if there is an issue with the FDA, given how favorable Secretary Kennedy looks at peptides, that I would hope that he would be able to kind of overrule and put them into that 503A eligibility. So that's where we are as of today. And this use evidence ladder is not binary and this doesn't work piece. This is all about, in the end, there's what FDA is looking for, and here's where another one of the crux are. So the FDA is looking for a peptide to work for a disease, right? Is this peptide good for this disease, or any drug? Most peptides are generally used in this process of kind of wellness, longevity, performance aging. Yes, they also have their role in conditions, which we'll talk about with each of them. But that's the area where there's no real law. So there isn't, when you start to talk about peptides and their value, it's not just that they work on a specific disease state or indication, as if they somehow have a pleiotropic value, right? They're helping to restore homeostasis in your body, which is a different concept. So the reason I'm bringing that up is I think that you're going to see, potentially, I can envision another category of therapies, not nutrition, not drug, but peptide, or peptides can be nutritional if they're orally taken, much like glutathione is oral. It's a dietary supplement. And when it's an injectable, of course, being a dangerous drug, has to be compounded for human use setting. It could go that way as well. So there's still a lot of questions. Safety outcomes were really important. We literally we reported, for example, on BPC 157, 16 million prescriptions in doses with only 3 reported adverse events, and they were minor. In all of these peptides, the adverse event reporting wasn't significant at all, really minor. So there was a lot of kind of making sure we just got the information right that's required by FDA. Now, real world evidence is highly accepted by the FDA. So, which is tracking patients. You use a peptide. The biggest issue there is in many cases, the people using peptides are using them in combination with other things, right? So they have them on some nutrients, maybe they're on bioidentical hormones, and they're giving them a peptide. So even when their outcome is created, a logical question is going to be, well, did the peptide do it? And in reality, it probably was a vital role in playing a pattern analysis that meant there was a need for several things to correct the pattern and get the patient better. So, the big criticism, not enough human use. And that's one of the big pieces that kind of came out in terms of BPC. But of course, now more of the studies coming from Europe, especially Russia, Croatia, are getting translated, being published. I know I have a paper that's coming out on dental inflammation, the alveolar dental inflammation, and the use of BPC and TB500. So there are human studies that are coming out. So once again, how do we make this work, right? This is the framework. Do you have a molecular weight? What is the form? Is it freebase? Is it acetate? And then what's the certificate of assay? Obviously, right now, the big thing is, is it being made in China? Well, all the GLP-1s are being made in China. China makes a lot of drugs. It's whether or not the API manufacturer, the active principal ingredient manufacturer, is known as a green label manufacturer. Now, that being said, there is a very big rush to start creating APIs from US laboratories. So there's 2 different issues that we had to clear up with FDA. One was, what about APIs? And the need for the FDA, who has green labeled a facility, to say, yes, you're an acceptable source. Are you checking up on them enough? And admittedly, they would say they're not. There needs to be improvement there. And then once that compound comes into a compounding pharmacy, the compounding pharmacy has to then identify it, characterize it, make sure that it is what it says it is. And then it's the dosage and delivery. What's the concentration going to be? What's the route of administration going to be like? How do you deliver the dose? Is it reconstituted? How long do you take it? And then, of course, the next is evidence. And it's, is it human evidence? Is it route matched, meaning how was it given? Was it a controlled study? Is there any kind of safety issues that were reported? Is any pharmacokinetic data available? And then, of course, adverse reactions, and are they being recorded? And I would say that the one thing that would pop up is for the secretagogues, things like sermorelin, ipamorelin, CJC, that they're known that sometimes you can get a skin wheel or a skin histaminic reaction, and it's a reported event. But in terms of serious reported events, the ones that you're hearing about in the news are from research labs for the most part. I mean, basically 99.9% of them. And I know because chairing the International Peptide Society, I teach a lot of docs and I get calls from docs and and this is regularly. Hey, I've got a patient. They went to DER. They were on a peptide. They didn't know that they were on that research peptide. It isn't like the doctor recommended it, but they're having this adverse event and they want to know, could it be the peptide and what can we do about it? And the reality is when it's a research use product, you don't know. And you don't know what the toxicity is in it. So how are you going to know what to do in the emergency room, right? So it's really important to keep that in mind and understanding that we all realize that there's probably gray market products at work. You've had patients come into you that they took it, it worked. The problem is the inconsistency. And by the way, people should not be buying things on their own that they can inject in their body. That's known as a dangerous drug. It needs your guidance. And then, of course, the sourcing of it, as I said, are they a registered supplier? How is it being, first of all, sourced, and then the final product before you stating, making sure the sterility is intact. So these are all important concepts that, we have to think through on peptides because I, I have to tell you, it's like it's the genie's out of the bottle. Peptides are going to be here, and I don't even know that they're going to police. I mean, I think the FDA's ability to police all the research labs, I don't think they've got enough people to do that. So I don't think that research is going to go away. I wish that it would. I think the way that it might stay is that if you start to develop INDs for those research peptides and you have the right data to go with them, then you could end up in a situation where a research company is doing, an IND and that's allowing for it. But in the end, you need for human use. You want it to be 503A compound list, and you want to understand what the guidance is around how do I use it, what's it used for. And so these were the categories. And so once again, it's interesting because you have to pick what the review is for, right? And so BPC, which works on wound healing, works on inflammation, works on ulcerative colitis. KPV, wound healing, inflammatory conditions. TD500 was wound healing. The dosage and routes of administration, BPC, oral, subcutaneous, liposomal. Obviously, it will go for uh, injectable. A lot of the human evidence, once again, limited. And then there's a route mismatch in that there's a lot of injectable. So we'll go through each one, how it may have value. KPV, any human evidence that's been published, really not yet, but the mechanistic research is pretty clear on KPV, and we'll kind of go through where that is being used. And I think it's probably one of the more valuable peptides that are going to be available. If you look at the AA there, that's how many amino acids long it is. So you look at KPV, why is that so valuable? One, it's 3 amino acids. That means it gets through the GI, gets through the stomach pretty easy. You don't get any proteases to attack it because it's under 7 amino acids long. TD500, same way. But we'll get more into detail on each of these. And then the other ones were MODC or MOTC, which is known as a mitochondrial peptide. And so where was it reviewed for obesity and osteoporosis? Route examples, subcutaneous, transdermal. I really haven't seen it oral. Injected, still limited, human dose response data. But very promising, right? A lot of folks using MOTC, especially with the amount of folks now that we're aware of mitochondrial issues that are out there, whether it's COVID long haulers, chronic degenerative diseases. people with diabetes, people who are obese, all have issues with mitochondrial capacity and function. And then epitalin, which, it was being reviewed for insomnia, typically subcutaneous, also oral, but it's probably its biggest value was in circadian timing or restoring the suprachiasmatic nucleus, obviously lengthening telomeres, great studies that show that it lengthens telomeres. So we'll go through that one as well. And then CMAX, which really it was studied in what was presented to the PCAT committee was cerebral ischemia, and migraines and trigeminal neuralgia. But where most people will use this is, it's going to be for anxiety and cognition. Those are the two big areas. Intranasal is probably the biggest. If you talk to practitioners, they usually will lean towards intranasal versus subcutaneous. There was a concern over whether or not there would be any kind of cerebral bleeding from it. There's been no evidence of that whatsoever. So that was the major concern that they had. So BPC, what's the rationale? So what's the reported uses? Tissue and wound healing, probably the most, look, overwhelmingly, what this was used for was, first of all, repair of tissues. So ligaments, bone ligament junctures, tears, tendinitises, labrum tears. Docs would inject in the area and it would accelerate their healing. I know for a fact, talking to orthopods, talking to physicians that, did, physiatrists, people that were working in rehab that were using this, absolutely attested to, yes, it definitely accelerated the time to healing, both for wounds and also for tissues. And it decreased inflammation signaling and decreased pain signaling. The other one, and so I would combine, the first cause and the third cause, injuries. Now, not a lot of use this in professional athletes. Anybody that's tested is not supposed to be able to use BPC, which I think is unfortunate. And then, of course, the mucosal support, which is typically given orally. So BPC 157 is made by in your stomach. It's called body protection compound, and it helps to stimulate the mucosal barrier. And so where clinicians were using this orally for mucosal support were people with food allergies, people with high zonulin, people that had permeable guts. They would use an oral form of BPC 157. You would not get as much of that connective tissue and injury functionality with BPC 157. The liposomal tablet, a lot of docs ended up reporting that there's some benefit there in the wound healing and tissue healing, but that's probably because it went into the lymphatic system and was distributed more versus, say, the gastric one. But either way, those are the biggest areas that BPC was recommended. Now, you'll see, it stimulates growth hormone. Well, not really. What it does is it actually makes the growth hormone receptors more active. That was it. So more active on growth hormone receptors. It does improve nitric oxide. One of the big concerns with BPC 157 is angiogenesis. So you will have other providers, or maybe you have a patient, maybe they've got a previous history of cancer, and it's like, do not use in cancer. Well, it turns out that 2025 paper showed mechanistically that that BPC 157 has selective anginicity, right? So that means that it's going to, when you have an injury, it'll help blood flow go to it, but it doesn't necessarily create budding to provide blood flow to cancers. So that is the current thought process on it. If someone's going through an active cancer, I wouldn't be giving them BPC just because, their oncologist probably ain't going to be very happy, even though they do need to protect their gastric barrier. So things like glutamine or other compounds that could help them reduce their oral mucositis could be really important, right? So the so is it a performance enhancing drug, a PED? Not really. It doesn't stimulate growth hormone, makes the growth hormone receptors just be more active. It's too bad it's not utilized because it could help a lot of people repair from their injuries much quicker. Uh, does it have a clear signal that it's a cancer promoting in people with cancer because of angiogenesis? No, because it's selective angiogenesis. And then from the FDA's perspective, you know, limited human exposure, not a lot of studies via the oral, subcutaneous, nasal, or transdermal routes. However, a lot of the studies that were done in Europe just they haven't been translated yet. And there are some studies starting to come out now. So I think we're going to see BPC play a very prominent role in peptide therapy because there's a lot of information kind of coming to fruition now related to that. Now, that being said, 16 million doses of BPC 157 from a variety of compounding pharmacies for human use, written by docs with only 3 adverse events. In fact, it had the second best adverse event ratio in the history of all drugs. It was like 0.003%, right? 16 million on 3. So it was amazing. So this one was the big one, right? That, when we got the voting for this, I mean, the crowd erupted. And I think it's mainly because for many of you who are listening, you probably had a previous history of seeing BPC 157 work and you really want it back. I know for me, you know, I saw it work on my meniscus tear. This was before the rulings in 2023, where the previous administration took it away. So BBC and TB 500, along with some PRP, totally corrected my meniscus tear. So on a personal level, I'm sure glad that this happened. And I think this is something that you can build programs around for healing and rehabilitation as well. So if you're a provider or you're a pharmacist, you're looking for what can we do, obviously the nutrients that support healing the connective tissue and bone are going to be favorable recommendations to go with this. Is there any contraindication with this? Not really. I mean, if you're used to using oral corticosteroids injections, giving BPC with it decreases the drying out of the tendons, which occurs in many cases, right? So that you can tolerate that better. So dosing wise, so these are not FDA approved. This is not this is just from for example, the monographs written by International Peptide Society, which is spearheaded, and what clinicians use. So if you're using it subcutaneously for an injury, 300 to 600 micrograms daily. Look, I'll just make it simple for you. 500 micrograms at the beginning of an injury. Say you get a little labral tear, a tweak, or a knee. 500 micrograms twice a day, typically, 30 days, and then evaluate. Is it, dramatically better? Is it healed? We done? Fine. There's no problem with staying on it longer. So you could, as a clinician, go, hey, you know what? You've got 80% better. I need you to do this for another 4 weeks. And so there would be no issue. If you look at the oral dosing, typically used for GI problems, 500 micrograms, once or twice daily. So you know how it goes. A dose shows up, and now all of a sudden, bigger doses mean better. But typically, 500 micrograms daily, up, and even twice a day, a milligram a day. And you may do this for more than 30 days. But at 30 days, you want to evaluate it. Hey, where are your food allergies? Did I take you off? Did I test you and get you off of food allergies and sensitivities? Are you chronically on NSAIDs? If you're chronically on NSAIDs or drugs that disrupt the mucosal barrier, you may chronically need to be on BPC. The liposomal BPC acetate, 250 micrograms twice daily. So the big key areas for BPC: joints, connective tissue, healing injured tissue, and then working on the gut, helping to repair the mucosal barrier. When people have poor bile acid utilization, right? The poor bile acid release ends up affecting that mucosal barrier. People that have had a lot of dysbiosis have broken down the mucosal barrier. So using BPC as a strategy to help rebuild that mucosal barrier, along with the obvious nutrients like glutamine, zinc, carnosine, maybe aloe, really makes sense. And look, today this is one of the biggest things going on with people. So these were the review. What was nominated was to have capsules at 250 micrograms, 500 micrograms, and 1 milligram. The subcutaneous injection at 2,000 micrograms per ml. The nasal spray at 50 mics per spray or 500 micrograms per ml. And then suppositories at 1 milligram, and then also a milligram transdermal cream. So these are all the different ways that you could consider it. Now, it's interesting on wound healing, before this happened, I remember talking with a clinician that would put that electrical tape, positive and negative charge tape, on a incision wound, right, that was sealed, and then drop BPC liquid on it. And actually, that positive, that charge drove the BPC into the tissue. And, the clinician was like, hey, these, incisions heal so much faster. So what we don't know, we don't have a lot of data on what the bioequivalence is between all the capsules. Nasal spray, maybe for neuroinflammation. I think there's probably other things that you could benefit with, but it's one of the things that got reviewed, nominated, and now is going to the FDA for final judgment. So here's the things that you may see. Injection site redness, that can happen with any needle. I haven't seen it much with BPC specifically, and over the years, I've used a lot of it. Rash can always occur. Remember the angiogenesis, selective angiogenesis, pediatric, no safety data on peds. All I can tell you is the general information of 16 million doses and 3 reported adverse events. Now, that being said, we're going to have to, be more diligent about, as we start to utilize these, is, be honest about it. If you get an adverse event, we got to be able to report them. But, I've been around enough practitioners that it's very rare. The gaps for the FDA, right? Where's the human studies? There were only 3 injectable FAERS reports. Causality was uncertain. They were not significant. There's not PK data based on the route of administration. And then, are there immunogenicity concerns? Typically, look, this is a human peptide, 3 amino acids or less. The FDA's own guidance said for peptides of 7 amino acids or less, we're not concerned about renal or hepatic toxicity. In general, well tolerated. So, this one is a 15 amino acids, a little bit bigger. And Then it's just, their concern of, aggregation, storage, but that's used when used correctly and compounding pharmacies are doing it, they account for that. And there's been no evidence of immunogenicity over the previous decade of use through literally thousands of prescribers. So, you know, the big thing to look at are simply these pieces is, what symptom are you going for? Is there hypersensitivity? I have not had a major, and I've got lots of clinic experience in this, and lots of healthcare providers that I've talked to haven't seen a lot of hypersensitivity to the injection site. Though the malignancy piece I've explained with, due to the new papers that are being published, other medications, obviously. I can tell you right now, anybody on an NSAID, anybody on a corticosteroid, anybody getting injections for corticosteroids, you would want to be on BPC to reduce that kind of side effect of chronic steroid injections into, the tennis elbow, right? So important to keep alive. So there's no valid database right now. Now, the interactions that are noted are positive interactions, right? So with an NSAID, it's protecting the NSAID against the GI bleed. So it's they list that as an interaction, but it's a positive. The corticosteroid already had stated, neuroleptics, it's theoretical. Anything nitric oxide. So if you think of the PDE5 inhibitors like vardenafil, tadalafil, is that a potential interaction? Not really. That hasn't been seen, but you do get some nitric oxide activation with BPC. And then, does it help with mood? Honestly, I haven't seen a lot of people that took BPC and said, hey, my depression lifted, although that's a proposed claim that you'll read about when you look at the literature. But, for the most part, these are all positive interactions that are occurring. Bottom line, the pharmacy needs to verify free base versus acetate, make sure that it's a route specific for the evidence and what you're used to using, and then report any suspected adverse events, of course. We don't want to have underreporting. Right now there's a feeling that it's being underreported, but honestly, with the personal use and listening to all the healthcare providers using it, I just think it's one of the safe peptides that really, I think, drove people to, being passionate about getting the rights to get these back. So this is probably one of my absolute favorite peptides, just because of using it in the past. It was basically being thought of as an anti-inflammatory, and then also to support gut issues, and then immunomodulation, and then also wound healing and inflammatory conditions. So basically, it's a peptide from melanocyte stimulating hormone. It's a fragment of a melanocyte stimulating hormone. If you're familiar with melanocyte stimulating hormone, you know that it, it tans you, right? Everybody that was using, you know, melanotan 2 were getting tanned up, right? So that part, there's no action with KPV. So even though KPV comes from MSH, it doesn't have any of the melanin containing or the tannin containing activity. It's simply a 3 amino acid peptide that has a lot of activity on inflammation signaling. And we'll go through that. It's basically it inhibits TNF alpha in the gut and shuts down NF kappa B in tissues. So, no human exposure with data was identified by FDA, and no clinical studies identified by the FDA. However, there were some, significant studies that were submitted to the PCAT committee, so that there's a little bit of a mismatch between what the FDA was supplying and what the committee was getting. So, but KPV's main benefit is basically that it downregulates inflammatory signaling in the gut. Acts very similar to a biologic like Enbrel. I think the advantage is, KPV is the natural Enbrel in your body. And as we all know, these biologics have a limited life with people. They habituate to them. It no longer works. And whereas this doesn't show any record of habituation. So dosing on this, mainly it is an oral compound, typically 500 micrograms twice a day. And then there's it could be transdermal. It's also used injectable. A lot of times this has been used with BPC in combination. Because if you think of it, when you're trying to work on the gut, BPC is healing the mucosal barrier. But what KPV is doing is it's regulating the epithelial cells of the intestine to stop producing inflammatory signaling. So you'll see this in, inflammatory gut issues, joint-related issues. Of course, a lot of us understand now that the gut's also a source of inflammation that affects the joints. So KPV, if it's liposomal, 250 micrograms, a lot of times you'll see this dose like 1 milligram twice a day, or the liposome would be 500 mics twice a day. And when it's for oral use, to start out, to really dampen that inflammatory signaling, and then you drop down to this dose. And once again, it was nominated initially as as a topical. They did not validate oral or injectable protocols. There was no USP or NF monograph on this. So yeah, FDA nomination was strictly topical, but the PCAC committee is for injectable, oral, or topical. So once again, the adverse event report, it's well tolerated. Actually, there were no side effects that were reported on and I have to go back into my notes. I think it was about 1.4 million prescriptions. So no adverse events. And I have to say, with the use of this over the last several years, I have yet to have somebody not tolerate KPV. In our clinics, we exclusively did it orally, but the injectable obviously is going to have some benefit, a lot of benefit in terms of shutting down that master switch for inflammation. So the unmapped mechanism, I think it's becoming fairly mechanistically clear that it's modulating Th17 cells in the immune system. It's downregulating NF-kappa B, and it's decreasing the expression of TNF alpha. And I would say that if I could use this every day, I would be using it every day for people, because it's very rare that people don't have either silent inflammation in their gut, or they're experiencing something, or they have looming autoimmunity. And that's where I think its greatest benefit is at. And where's the FDA gaps? Again, no clinical studies on human exposure data, no PK data, no real FAERS cases. There was none established, none reported. Nothing's been reported on this as an adverse event. So from their standpoint, potential risks in humans remain unknown. I would say that, once again, the purpose of the applications for 503A is, can you identify the sulfur-free base? Do you know the molecular weight? Do you have a methodology to test it? Do you have a history of use from providers? And then if you have safety data, do you have it? That's it. So whether these gaps were there, this is more looking at it from the standpoint of, gee, we want this to be a new drug, and that just isn't going to happen. So one of my favorite peptides by far. So once again, if you inject or you put it on, just monitor, hey, is the skin irritated? What could be the base that it's in for that matter? Do you have hypersensitivity to KPV? I doubt it because your body makes it. But then, is it effective? If you're using this, I usually tell people when they're working on their gut or they have like pain, inflammation, kind of that pseudo autoimmunity or looming autoimmunity, use these kind of compounds for a good 8 weeks. And if they're not working, probably not going to work. So adding BPC, KPV together, helping, the gut to heal, that's really the where you would say, okay, am I getting better or not? Now, typically, if it's a gut issue, you're probably putting them on a food elimination diet. You're killing bad bugs. You're putting in good bugs. You're giving, maybe a digestive enzyme, right? Or you're finding out why did the gut go wrong to begin with? Was it medications, whatever? So, in the case of KPV, I think it is you get allowed to use this again. I think this will become one of the more heavily used peptides that was really just starting to get notoriety until 2.5, 3 years ago. No established interactions. I don't think you're going to see interactions with KPV. I mean, maybe in the delivery vehicle, but once again, remember, it's not acting like melanocyte stimulating hormone, so it's not having an effect centrally in the brain. It's not tanning your body. So it's really well established, in terms of, I think, safety profile. You could get very comfortable. And what I would say to you of these 6 peptides, if you're new to peptides, just try a couple of them, right? Try to work on as they come out, the 2 or 3 you're really comfortable with or fit your population. That's how I've always taught it. I think a lot of times when these first came out, everybody is injecting 10 at a time. Too much creates a mixed signal. It's a lot to handle. And then you don't know what's helping, and particularly what you might be reacting to when we're given too many of these at one time. So bottom line, 3 amino acids, very simple, can pass through the gut easy. Topical, I haven't had any experience on topical, so I can't give you good insight on it. And once again, when would you stop using this? Probably if you got the inflammation under control. So if you corrected somebody's gut, put them on an elimination diet, got their stress under control, maybe they had environmental burden that was contributing to their gut. So if they're cleaned up and they're not having any source inflammatory signaling anymore, they may not need to be on KPV. But in general, they may need to be on KPV. So it's okay if you're on this for a longer period of time. This is very preliminary, but BPC and KPV, BPC knee review, 16 followed, 14 reported pain relief, no comparators, so no blind. KPV cell and mouse colitis studies showed signals, no human, not human efficacy, but showed efficacy in the mice study. No validated function tools or imaging. Structural repair hasn't been proven. So, pretty much, I think you're going to use this, especially in your GI folks and your folks with that diffuse kind of, I would say almost obtuse pain, right? They're signaling inflammation, but they may not have I think it's my L5, and you do images on them and there's no problem. It's just inflammation signaling. The third one, TB500. So you hear TB4 and then you hear TB500. TB4 is the full length thymosin peptide B4. TB500 is the fraction of TV4. So just trying to make sure you're understanding the difference. It's 7 amino acids long. It is, there's a molecular weight that's there. It was reviewed for wound healing. Where is this mainly used? It's mainly used for tissue healing. So, like, post surgically, connective tissue, um, maybe bone issues. Sometimes also people would use it in people that had immune deficiencies where you wanted to activate some of their thymus, killing potential or immune potential. Because a lot of times, obviously, as you age, your thymus gland gets smaller, can't make as much T killer cells, the gamma delta cells get worn out. So if you see the difference between the two, see thymosin beta 4 is 43 amino acids. The thymosin beta 500 is only 7 amino acids. So protocols, 300 micrograms to 1 gram sub-Q daily. I would say if you were injecting this, you would be injecting it with BPC most likely. So typically 500 mics plus 500 mics twice a day. Use it for a month, see how they're doing, and then decide whether you need to restart it or not. Longer use, 3 months on, 6 weeks off, 6 weeks on, 6 weeks off. There's no magic to it, guys. I'm telling you right now, nobody really knows. Nobody really knows, what is the exact cycle. And I think that in general, once again, it's a thymic peptide that your body makes. So if someone needs to be on it for more than 3 months, they're not fully healed, you're probably safe in that consideration. But you could also take off 4 weeks and get them started back on it. The review was for IM and subcutaneous. The FDA basically reviewed the TB500. And then there was, from their standpoint, no standard concentration established by FDA review. However, no USP monograph. However, concentration, molecular weight, all defined in the 503A space. Adverse events, once again, pretty well tolerated. Stiffness or redness at the site. Cycling limit, is emphasized, meaning on 3 months, off 1 month. And again, prohibited by WADA. That's on their most current list. I think it's too bad because one of the biggest things, the Olympians, for example, they train for 3.5 years, 4 years. They go to the tryouts and they get sick. Why do they get sick? Because they trained at a very high level. Cortisol, adrenaline, noradrenaline, 3 years, and inhibited their ability to fight off infection. And these are things that would help them not to, limit their time or, create a world record, but allow them to be able to sustain their ability to work. And it's, too bad that that's not seen. You will see this combined a lot with BPC in order to enhance healing. So definitely improve when you do the two together. If it's joint or connective tissue, you definitely see a significant improvement. Once again, same evidence gaps. This was the argument all along from FDA. And from our standpoint, once again, it met the criteria for 503A. And then we're going to have plenty of people that will start to report the benefits. The real world evidence will start to roll in over the next few years. I know we're planning on programming that will, allow for people doing those types of submissions. So get the right compound, make sure there's no interaction, make sure it's not an athlete that's using it. If you're going to do wound, I think it requires treating the wound as well, whether you're using, sugar granules, or you're using nitric oxide to support, blood circulation to the injury, any number of those things. So once again, the immediate interaction really has not been seen that much. Not a lot of people are getting anaphylaxis to TV500. However, there are some people, because it is an immune stimulant, that they may notice themselves, oh, wait a second, I got a little sore. Um, Honestly, it's you using your clinical judgment. It's going to be rare, but obviously, anything you inject in your body's pretty dang complex. You you could very well end up with an adverse event that should be reported. So make sure you got the 7 amino acid fragment. You know, there's some angiogenic activity with this. I would say this is a little stronger. So in terms of like a cancer patient using TB500, you would use thymosin alpha 1, which we're not going to talk about today. But thymosin alpha 1 has human studies on it and is absolutely wonderful for patients with cancer. So, that's a peptide that I think is going to pass in February. It should, because it's already a drug called Zadaxin, right? Zadaxin is thymosin beta 4, or thymosin alpha 1. I'm sorry. So, bottom line, make sure the labeling is clear. Got a before use date, strength of it's clear. You can't really infer human efficacy from the full length TV4 studies. So the fragment information is not the same as the TV4 information. Keep that in mind. And then there's no real cycle schedule that's been validated. That's why I'm telling you, you may have a 2-week break and then say you want to get people back on. Fourth, one of my favorites, MOT-C. So why MOT-C? Well, it's really because with MOT-C, recently, mitochondrial issues have become at the center of everything what we're looking at, right? If you're into integrative care, functional medicine, regenerative medicine, if you read the COVID long hauler papers, right? The COVID vaccine papers, chronic illnesses like um, Parkinson's, diabetes, loss of mitochondrial capacity, depression, right? Loss of mitochondrial capacity is associated with all chronic degenerative diseases. So there was one that was approved about 3 months ago. That was SS31. SS31 is a mitochondrial peptide that got approved. And now a lot of times people will alternate SS31, and as SC becomes available, it will be alternated with the SS31 to be able to kind of get mitochondrial rejuvenation. But once again, on mitochondrial rejuvenation, there's things that you need to do. One is people need to be on phospholipids. Phospholipids help to repair the mitochondrial membrane, both the inner and outer mitochondrial membrane, so you don't get electron leakage. If you're using this with, say, GLP-1s, for example, very interesting, because GLP-1s actually improve mitochondrial density and function. And so using them together could be very interesting as this becomes better characterized and the FDA allows for it to be compounded again. Cardiovascular support, bone health. Well, MOTS-C, guess what needs a lot of mitochondrial function? Heart tissue. And so as we know, people that are overweight and insulin resistant end up with left ventricle imbalances. They start to grow their left ventricle. Keep that mitochondrial functioning, allow the muscle to be able to function appropriately, and you have less risk of that left ventricle enlargement. FDA was using this. Obesity and osteoporosis were the triggers. I honestly, I would say that for obesity, this is this good secondary player. But as people's thyroid function get lower, their cortisol is higher, their insulin resistance is higher, all features of people with weight issues. Mata C is going to help restore their energy. A lot of people you talk to, even after they lose weight, they don't have good energy. And so using this mitochondrial peptide, it activates a couple of things. One is it upregulates kinases that help with mitochondrial renewal, and then helping with mitochondrial repair are the two aspects to this. So, not a lot of data here. So, not approved as a drug. It is absolutely in the pipeline for drug therapy. So there's the current ongoing trial for adults with prediabetes right now. So the studies are going to be coming forward here shortly. So how would you use this? Once again, just to reiterate this, these are clinically utilized. So this is how people use MOD-SC. Physicians that are trained in peptides that utilize them in their practice, typically 5 to 10 milligrams twice a week. It's kind of pricey. A lot of people go to 10 milligrams twice a week, so it gets kind of pricey. But there are a lot of people that swear by this for giving them energy. And I think the older you are, the more you're going to feel it too, or the more that you've compromised your mitochondrial function due to either the exposome or what you've done to yourself, right? It's one of the two. So what would you look for on this? Sometimes people get excitable on this. It really hasn't been, I would say this is more what I see is they feel a little bit revved up or anxious or nervous the first few times they're on it. A lot of times back when we had this, we would ramp them up at 2 milligrams 3 times a week. 3 milligrams 3 times a week, and then go to 5 twice, 10 twice, just so they don't have that kind of potential for feeling anxious or revved up. It was nominated at 5 and 10 milligram injections. The free base and acetate were evaluated separately, and oh, by the way, they're both approved, and there's no USP monograph, no NF monograph. There could be once they get nominated to category 1. Once again, the adverse events, site stiffness, redness, or pain. I'd agree with that. I mean, when I've used this in the past, and I have used it in the past, it stings a little bit. You'll feel it the next day too. It potentially can cause folate depletion. So the methyl tetrahydrofolate can be a problem. So you may need to use folinic acid or methyl tetrahydrofolate or in between your injections of this, and then also look at homocysteine. Where's your homocysteine at? And obviously look at your folate status, but that'll show up with the homocysteine if it's not there, and then you start doing this. Same piece, evidence gaps. I'm going to keep going back to the safety on this. I think on this was 600,000 people with no significant adverse events at all. So the immunogenicity, I think, is really kind of, I think it's validated at this point because there's been absolutely no reportings of it. But it'll have to be formalized as we're used to. And then, most of the studies are animal studies. Some human studies they're going to start populating on this now, especially since we can now measure mitochondrial function more accurately. kind of traditionally it was surrogate testing, and now we've got, of course, the seahorse mitochondrial test, which is accurate for how much electron leakage, how much oxidative damage, how efficient are the mitochondria at rest, how efficient are they under duress. It gives you a lot of information on mitochondrial activity. So I think that with that being said, now we can do a direct test. I think we'll find out, where the actual dosing on Mata C is needed. So, you know, look at if you're using it for weight loss, and I would suggest it gets used with a GLP-1 if possible. You could obviously use it without it. Um, so that would mean regulate. It's that first two bullet points together. I think it's, in America, weight loss is 80% glucose and A1C, but then you got to figure out what's causing that. Is it due to trace mineral deficiencies like magnesium and chromium? Is it due to uh, environmental burden? It's well known now. Forever chemicals, plastics, arsenic, metals can interfere with glucose regulation. So you have to keep that in mind. And then, of course, you're going to watch for the homocysteine and the folate issues. And that injection site hypersensitivity, I would just say it's going to be a little sore for a day. Like you're going to feel it. And I don't think that is a problem as much as it's not red, it's not swollen, it's not erythremic, it's not a wheal. It's just feels a little irritated. Once again, no interactions, no proven interaction with methotrexate. Why? Because methotrexate depletes folate or any other anti-folate agent. I would just look for folate. You don't want to give folate automatically. If their homocysteine's going up or they show other symptoms or signs, then makes sense. But don't do it just for the sake of, it could deplete folate, therefore I'm going to give it. Oop. So, see if there's anything here. Yeah, bone loss. It did show support on bone loss. And then also AMPK regulated. So what is that doing? So when you get AMPK dependent transmission, that upregulates something called PGC1 alpha. PGC1 alpha is kind of that signal substance that upregulates mitochondrial production, helps to activate. It acts as a co-activator for many of the receptor substrates for hormones and neurotransmitters. So this is pretty key. If you see here, the one study, lower endogenous Mata C and type 2 diabetes, yeah, it makes sense because people with diabetes have the Warburg effect. The Warburg effect is that passive diffusion of oxygen or of glucose into their cell. They create a lot of waste, a lot of pyruvate, a lot of lactate, not a lot of oxygen, and not a lot of energy. I mean, so you're not packaging up a lot of energy like you should. You're like making 2 packs of energy when you should be making 32 packs of energy. And so people that are in that pre-diabetic, diabetic space, their fatigue could solely be due to the fact that their mitochondrial functions has been really, washed out. Same, normal lab results don't mean proven safety. However, the safety signal was good and therefore validated to be able to, vote this in from the PCAX perspective, at least what I saw. And I thought this is kind of one of the biggest areas that we need solutions in right now. You don't have a lot of mitochondrial targets. Yeah, urolithin A, maybe, fisetin, maybe, right? The senolytics that also may be stimulating the mitochondria, using CoQ10, good. But, this is squarely helping people that have pretty compromised mitochondrial function. So like the COVID long hauler types, this is going to be a big help for them to be able to utilize this again. SS31 also, this isn't quite as expensive as SS31. SS31 is pretty pricey. So I would encourage you people that are fatigued, that have some of these cofactors, have them try MOT-SC. I would do this, by injection. There's a topical that's being worked on right now that I've seen that might provide a different way to do it, but for right now, it's injection only. So number 5 is epitalin. And epitalin, look, this was made famous by a Dr. Cavison, who did research in Russia. And what he did, and I could have put the study in here, just for the sake of time, I didn't want to drown this down in too many studies. But what he did was he gave epitalin in this elderly group. If you think of a bunch of elderly people between 65 and 79 years old, and they all had heart disease, all right, significant. He gave them epitalin and tracked them over a period of years. And what he found was the people on the epitalin had a 65% reduction in their mortality rate. So it protected and helped to reduce the progression of their heart disease and comorbid symptoms. And that's mainly because it helped with activating the suprachiasmatic nucleus, of the brain, which it works on the pineal gland. And why that's important is that what it's doing is it's telling all your other hormones for the next 24 hours what to do. So you're regulating the circadian nature of all your hormone releases, because as you guys probably know, when circadian timing is off, say for example, sleep apnea, people on night shifts, people who aren't getting enough sleep, their beta cells don't get adequate signaling. So your insulin regulation is off, testosterone's off, estradiol's off, thyroid hormone release, cortisol curve gets flattened. All those things lead to kind of this pleiotropic movement towards accelerated aging. And that's where I think, as we think of longevity medicine, if you think about people that are night shift workers, if you think about people that have trouble sleeping, if you think about people who, you're giving them hormones, but it's not quite working, and they're not sleeping well, you think of epitalin. One of the biggest things that epitalin also does is it helps with telomere lengthening. It doesn't mean you're going to have telomeres that, if they're already long, that it makes them extra long, which is what people worry about them for, oh my gosh, is this going to create cancer? But in people with short telomeres, it definitely increases them. And so that's been published. So Russian cohort studies, observational data, no US data. And they didn't really accept the safety data as it relates to the studies that were done in Russia. And then there weren't big insomnia trials. But however, once again, there isn't a need for trials. There's a need for a history of use by providers, a ability to identify the compound, right? Molecular weight, spectroscopy, HPLC. We can identify the signals in that and know that we have the right compound. That's it. That's what's needed. And then if you have it, safety use, and this is another compound that you had hundreds of thousands with no safety signal. Our bioregulators, or the oral form of epitalin, has been used a lot. Same thing. A very safe compound from what was able to be collected from a dozen compounding pharmacies that were getting prescriptions for human use by healthcare providers. This is, for me, I really believe, just like KPV. So when you think about aging, right? Metaflammation leads to inflammaging. BPC helps with inflammation. KPV is a big one for targeting inflammation signaling. MOTS, because with aging comes mitochondrial raggedness, or medications like statins or metformin over time. can cause mitochondrial raggedness if you're not giving adequate CoQ10, if you're not supporting the mitochondria. So this is one of those situations where it's not about the drug being bad or good. It's just that you're going to support the downside, the risk side of it. Same thing here with epitalin. As people age, their circadian rhythm gets thrown off. Elderly people don't sleep as much. So I look at this, and the ones that were approved as key agents to help people. When I hear the term longevity, I mean, what I'm really all about is performance aging. We don't know how long we're going to live, but can we live as healthy as possible as long as we can? Can our lifespan meet our health span, right? And if we can, can we extend human life with all the new things coming out, gene therapies and, you know, use of certain biologics, stem cells, exosomes, cell factors? Sure. Whole other topic, right? But I think when you think of epitalin, just think of sleep, people that are old. But the other one is people that have thrown off their HPA axis because they've went into allostatic load. So people with high cortisol or people that have flattened their cortisol curve, epitalin is going to be very important for them, right? Because when you flatten your cortisol curve, you create hyperarousal of the HPA axis, which induces a hypervigilant brain, and therefore you can't sleep at night. So, what is the reported dosing? Once again, these are not FDA approved dosing. And remember, these have not been put on category 1 yet. Just to reiterate that, but the oral dose would be 10 to 20 milligrams twice a day, 30 minutes before meals for 1 month. Now, I'm telling you, you're going to read, if you start reading about these, and obviously I've got a peptide handbook for healthcare professionals. I think it's third edition's coming out here shortly. Every 4 to 6 months, you would repeat that oral dose. The study that Cavison had performed was 10 milligrams, either 10 milligrams every 3 days for 15 days or 10 milligrams a day for 10 days. And then you would do that every 6 months. That was that elderly study. You will see people that are using 2 milligram doses 5 days a week. So that's more to try to re-regulate on a chronic basis. Yes, I'm chronically stressed out, not sleeping well. Maybe you're, 60s or 70s or elderly. I'm not going to call 60s elderly anymore since I'm in my 60s. But you can certainly use it that way as well. But the classic way you're going to read about this will be the twice a year dosing for the subcutaneous injection, or if it was oral. Cavison did it as an injection, 10 milligrams, 10 days in a row, or every 3 days for 15 days. So it's pretty clear what was done successfully. So what were the strengths? 10 milligrams per ml, 3,000 and 3,000 micrograms per ml. Freebase may not be soluble enough for the 3 milligram per ml. That's what the compounding pharmacy is going to work out. The listing of the dosing will be on the bottle. So once again, refrigerate. Absolutely, you can refrigerate this. Most of the injectable peptides, it's recommended to refrigerate. And then also follow the before use dating, right? The BUD dating. All right. But, and what I have seen is they're, once made, they're very stable, but we do have to, because they are for human use, individually made, they have to have a before use date on them. Telomerase upregulation, that's the big, is that an issue as it relates to potential for cancer? Turns out, not really. Really hasn't been reported at all. Sleep claims thought to be related to improving melatonin because you're re-regulating circadian timing of your hormones. That makes sense because cortisol should be going down at bedtime, creating the activation of melatonin in order to put you into that slow wave sleep, right? You need to go into If you do not go into deep or slow wave sleep, you end up creating, a situation where you don't stop making corticotropin releasing hormone. And when you keep making corticotropin releasing hormone, you inhibit growth hormone, which accelerates the aging process as well. So it's important to understand the circadian timing piece. Evidence gaps, once again, this is all because it's not a drug yet. It notes this mechanistic carcinogenic potential. It just hasn't been shown. There haven't been any reports of allergic reactions or immunogenicity concerns, and no human clinical trials for insomnia identified, but the quality of life, reduction in mortality, improvement in comorbidities in the elderly, all were in the cohort studies that Cavinson had done. So sedation, I mean, when this was available, used a fair amount of this. I think people that are using it for sleep, you're going to get some benefit, but you're still going to have to manage the daytime stress. So maybe you're using something like C-Max during the day, or if you're using a botanical like Relora or theanine, you can use something during the day to calm down the hyperarousal, the HPA axis. Haven't seen many people being sedated by this. In fact, I can't think of one. Um, would you give this for someone that had a malignancy or proliferative history? I think that's a clinical decision on your part. Probably shy away from it because it's in the literature. But in general, if you're going to use this for insomnia, you're typically going to be working with some other agents as well, because this is really more of a circadian renewal compound. Once again, no establishment of any side effects that have been seen. So hopefully, over time, we'll continue to see the safety signal the way it is right now, where it's very safe, effective. Haven't seen people, managing adverse events. Typically, when you see like a cancer that's been reactivated, people are all over reporting that. We just haven't seen it. I don't think this is necessarily one of the more popular peptides on the gray market space. They're more eaten up with doing the GLP-1s and the growth hormone secretagogues. And actually, this is one of the more valuable ones. Same thing. The studies were all, there were older human studies. Epithalamin is the pineal natural, agent. The epitalin is the derived or synthesized agent. The 12-year epithalamin study reported low mortality. And then, of course, this was, these are older studies, so a little bit of constraint. But there were some human studies for this. Bottom line, increase in melatonin is not the same as demonstrated insomnia efficacy. Yes, it definitely increases melatonin. Polymerase claims definitely are there. Uh, those are the biggest issues around epitalin, frankly. And then the last one, before we get on to doing our questions, and I think I'm leaving enough time for us to do our questions, it looks like. CMAX, so we've got so many people that have issues with anxiety and mood. And the FDA review here was for cerebral ischemia and migraines and trigeminal neuralgia. Where this was used overwhelmingly was for anxiety and focus. Those are the two big areas. Minor applications with migraine, but honestly, it was more neuroprotection, cognitive support, anxiety, and stress. And look, I think we need to be looking for other compounds other than anxiolytics because they're so hard to get off of. Once people are on, they never can get off. And as we well know, in many cases, when people were anxious or if it was triggered by something, post counseling, getting their nervous system realigned, getting off of the antidepressants or anxiolytics can be difficult. And they have side effects, right? So I'm really encouraged that CMAX was, included, got voted on from the safety standpoint. And then the other piece is that it, intranasally seems to work really well. So you don't have to inject yourself. You can do an intranasal application of this. And back when we could use it, I found this to be really effective to help people to calm down that baseline anxiolytic state where the benzoreceptors need, some support. This is mainly GABA. So this actually activates, GABA receptors, which obviously decreases glutamate activation. So when we look here, where's the evidence? Obviously, it's limited onto intranasal. Not a lot of safety data on the subcutaneous use. There are Russian trials. Once again, I'm telling you what's happening right now is there's a lot of this information that's getting translated into the literature for the US because other areas of the world have been using peptides for a long time. And, obviously we did too. I mean, we used insulin. Insulin's a peptide, 100 years old. TA1 or Zadaxin, that's for hepatitis C. Valesi, you know, PT141, right? These are peptides. So the peptide terrain has been around. It's just that we really haven't focused on them as a part of our process versus, say, in other countries or other providers where they may use peptides a lot more frequently than us. In particular, Russia's a huge leader in this particular space. Typical dosing on Cmax, if it's subcutaneous, and I usually, if people are going to dose on this, I recommend that you have them try it. You could do 200 to 300 micrograms initially. The only thing that I would say that I've seen is that sometimes people feel a little bit ramped up initially, which is, if you read about it, seems a little paradoxic, but it it does happen occasionally. So if you're going to do it, start with a smaller dose, 300 micrograms once a day, or 300 micrograms every other day. If you're going to do it intranasally at 0.1%, you know, spray up each nostril, one nostril in the morning and one at night. And then you can use a much stronger, as you notice here, 10 milligrams per ml, which could be drops, it could be a spray. And once again, you're going to titrate that dose. And it is reported that you get, injection leads to desensitization, whereas, intranasal, it doesn't seem to happen. So once again, it was nominated both at intranasal and subcutaneous strengths. The literature that was reviewed by the FDA was intranasal only. From the FDA's perspective, it could not determine free base versus acetate. It's interesting because acetates kind of is a part of the manufacturing at times, so there may be residual. Once again, the C of A's on this are pretty clear. You can get an accurate pump for an intranasal in terms of dosing. And so this has been very, I think, for a lot of people who had their moods managed with this and they felt calmer, clearer, more focused. When this got taken away, it was traumatic for them because it was what was helping to keep their brains from being hyper excited. Once again, as with all injections, the chance for erythema, rash, edema, muscle and joint pain, really had not seen that very much. From the sedative side, Selenk is another peptide that is used commonly with this. And I've seen both Cmax and Selenk be sedative. So you just let people know when they use this that if you're, use it at home. Don't jump in your car after you get the bottle and get excited to take it. Just find out how you feel when you're using it. Real important to understand that. And then gaps from the FDA side, obviously, this was all kind of consistent throughout. However, I'm going to reiterate, we had put together a lot of data that they had not seen. So from our end, the safety signal that the ability to show safety was evident. Hundreds of thousands of bottles that were written for um, a clear molecular weight, clear identification of the compounds, all the things that were needed in order to satisfy it for 503A. So, monitor potential interaction with anticoagulants, especially in the injection, not so much on the intranasal. You could feel sedated. Actually, in general, most people just feel more calm, more clear. Depending on how it's made, nasal irritation can occur, and then injection site redness if it's subcutaneous. Once again, collecting this data, it's going to be an ongoing process. So this was the studies here: altered functional connectivity and imaging endpoints, intranasal rat study, BDNF rows went up. So where you see Cmax is improvement in BDNF. You'll see it written about. Activation of GABA or an agonist to GABA, which also helps with dopamine. But there hasn't been any long-term Cmax for cognitive, permanent cognitive capacity. I would say that, of course, because if the person's got, insulin resistance, eventually the insulin resistance or the inability for the brain to use glucose correctly is going to overwhelm what this is doing, right? So make sure that there's no big bleeding risk, no PKI. The nasal dose, make sure that's calibrated well. I gave you those doses. So, so you look for these, right? As clinicians, in particular when you're adding peptides and people are on medications. I just had a guy literally in this office this morning. I had a gentleman, he set down his list. He's on 10 medications, 14 supplements, and a lot of the medications were overlaps. And then you're going to just add a peptide. Well, obviously came in wanting to talk about peptides. Everyone wants to talk to me about peptides nowadays. Even though I'm very passionate about nutrients, botanicals, bioidentical hormones, and other compounds. But you got to clean things up first. I'm going to encourage you, if you're going to enter into peptides, try to learn about what nutrients could help them. For example, we talked about MODS-C. Magnesium would help the mitochondria. CoQ10 would help the mitochondria. PQ2 would help the mitochondria. So kind of understanding that get the more you could help a person to clean their chemistry up, the better that it's going to perform for them. Now, that being said, if it's just an injury, not a big deal. Just an injury, the BBC is probably going to work one way or the other. But then I would ask, why did they get injured? Was it nutrition status issues? Because 40% of all non-contact injuries are due to imbalances in nutrition, right? So what this is kind of talking about is, the areas where there could be issues, like injection immunogenicity. Look, that can happen, especially with the secretagogues. That's why you're supposed to, on secretagogues, which we did not talk about today because it wasn't the 6 on the list. But sermorelin, soon to be on the February list, ipamorelin and CJC, people can get immunogenicity. So it's recommended that they do, 5 days on, 2 days off. And then, of course, look for all the other areas. If you get topical irritations, it could be a preservative in the sinuses that's causing an irritation. Obviously, the quality interactions, which endotoxin, forever chemicals, wrong salt, impurities, that's rampant in the gray market. It kind of gets a little annoying when there's the thought that people don't realize that the FDA is coming in and expecting compounding pharmacies all the time. And they're wanting to see their batch records, and they want to see their SOPs, and they're looking to make sure that there's safety involved. So from the bulk side, once again, the bulk needs the exact sequence of amino acids. Is it free base? Is it amino acid? What's its molecular weight? Can you test for that? Does the C of A create identity impurity? Does it have related any kind of solvents? Is there any, and many times they're stacking peptides within one product. Not so sure about that one. And then, of course, the compounding process. And that's all about what compounding pharmacy does, right? They're going to have an operating procedure that gets to a final product that's safe for human consumption, right? And then, what's the finished product? So really important to realize that it's, pharmaceutical elegance, of course, being a clinical pharmacist. And when I went through pharmacy school, learned compounding and taught for PCCA, Professional Compounding Centers of America. It, you know, we're doing it responsibly to help the individual needs of a person. And even though the FDA does not have monographs on these, the International Peptide Society has monographs on all of these. We've written 80 monographs on peptides with all of the evidence, the level of evidence, so where is it at? Is it in vivo, in vitro, level of human study? Is it a case report? We've done all that. So, when you start thinking about what are you going to monitor, these are the key things that you think about monitoring. I mean, I just have to be honest with you. For example, on BBC 157, I have not seen like a worsening of symptoms from it. I've not seen any dizziness from it. These are things that get mentioned theoretically, but I mean, I put this together for you so that you have them. I think in general, when people have side effects, all of us as clinicians are pretty good at identifying them, and then we ask, "Hey, what did you do that's new?" Right? The biggest problem is, honestly, because a lot of these are used short term. The biggest problem you have is a lot of times people are on drug therapy where the side effect doesn't show up for 6 or 12 months later because it's a drug nutrient depletion. MOTS-c, obviously, I would say excitability, neurologic symptoms, hypersensitivity. I think that's realistic. That sometimes people, they get the mitochondrial function up and running, and all of a sudden they have all this energy, and it's, it can, you start creating receptor signaling quickly. So that, once again, why do you ramp the dose up? Just like you ramp doses of GLPs up, right? You titrate. With epitalin, the biggest concern being, is there malignancy? I just haven't seen anywhere where that's been reported, but because of the mechanism of action, it's an associated potential risk. And remember, if you held drugs to that standard, you won't be able to give any drugs out because everything's interacting with everything these days. And certainly we have a lot of people on a lot of medications. And then the CMAX side, I would look for at least petechiae. Do they get headaches when they use it? Seen that a few times. Mainly, are you over sedated? That's the biggest problem. So, what do you do? Obviously, keep in touch on the regulatory status. Make sure that it's the exact name. Rely on pharmacies that are for human use. 503A, doing things the right way. Obviously, if you notice something, a negative reaction, report it. That's how we learn about these things. But I think you're going to be very happy with with the safety frequency that you get out of these, because before they were taken away, I mean, we were using a lot of these in our clinics. And then also I was getting tremendous amount of information from the hundreds of doctors at a time we were training about the benefits and the low risk. So, build a workflow, right? Obviously, be clear about what the doses are you should give, what you're looking for. Obviously, you're going to rely on your partner compounding pharmacy in order to help guide you on the appropriate strength, the appropriate final formulation. Pharmacy team, from that standpoint, you already know this. It's correct calculations, correct certificates of assay, the color right. Is it consistent? And then, when there's a mismatch, you guys dig into it. So that was a mouthful. I'm ready for questions now.
I know. I appreciate all your thoroughness, Jim, and that review and clinical information I think is so helpful to our providers. I know we're super excited to even get to replay it on our end and share it with our clinical staff. And your insights from the FDA meeting were also super interesting. We did have a few questions that came across, so
Great.
let me pan over to those. It seems like most of them were surrounding BPC 157 and its popularity and use. More specifically, how does it work in frozen shoulder? It almost is a tongue twister there.
Yeah. Yeah, I mean, look, with frozen shoulder, you have nerve conduction issues as well as a lot of ischemia. So you've got the fascia that's kind of blocked, and so in conjunction with physical therapy, uh, BPC, I would probably add KPV to that. Should work really well to accelerate being able to kind of liberate the shoulder, break up the ischemia, improve the fascial release. Because what's happening is you get an increase in metalloproteinases in the connective tissue. And so the BPC and the KPV both help to reduce the metalloproteinases like metalloproteinase 3 and 9 that are upregulated in that collagen matrix that's triggering a lot of that inflammation. And so it'll be helpful for sure.
Excellent, thank you. Another question in relation to BPC 157 was, would recommendations change for chronic use of BPC 157?
Yeah, I get asked this a lot because nobody wants to go off it once they're on it.
Right.
It's like, I love this stuff. I'm not hurting, right? Um,
Yeah.
Yeah, I mean, honestly, it typically, if you're going to use this chronically, say you're training a lot, or maybe you're a 55-year-old female, you had an injury on your knee years ago, and BBC 157 is helping your knee to feel better on a day in and day out basis. You would more than likely go to a 300 microgram dose, and you would do that 5 days a week, take 2 days off. And then, if they notice during that month when they go off, it hurts. Okay. You remember that doctor, it hurts when I go like that? Okay, then don't go like that. Stay on it 5 days on and 2 days off. It's going to be okay. There's no, these are compounds that your body makes, right? So literally in my opinion, that and look, I've written databases for the APHA. I mean, I'm very, I would say, I'm aggressive on trying to help people get well, but I'm conservative when it comes to making recommendations that are risky. In general, the peptides offer a phenomenal safety profile. That's why, like DPC, yeah, use it pretty commonly if you need to. Myself, I train a lot. Um, when I was able to use it, do it a couple times a week. I wasn't really, sore that often, but I would do it a couple times a week just to reduce that risk of getting kind of chronic inflammatory issues in the connective tissue.
Yes, I think a lot of the information you shared about safety data in front of the FDA was probably very helpful for our prescribers, because I think that's probably a lot of the glaring questions surrounding, my patients come and ask me for it. Should I, prescribe it? And
Yeah,
so,
as it's safe for me to use. I mean, we worked uh, a long time on collecting that data. I mean, we had 9 million prescriptions collected 3 years ago.
wow, that's
Yeah.
substantial.
Yeah. So, I mean, yeah, it's important to feel as if you can do it. I mean, and the other thing a prescriber has to ask themselves, am I more comfortable prescribing it from a compounding pharmacy for human use that I can trust for a patient that's interested in using it, that now I have the dialogue with them and the understanding of the risk benefit, and that's how you safely get into individualized care, right? And so I think versus, oh, hey, I don't really know about that, but you can go, you're going to go buy that in some research joint, and then they end up having an adverse event. So for me, it's more about taking back the clinician's rightful place.
Yes.
That's what I was concerned
Yes,
about.
I heard that voice many times during that meeting, which I was glad to hear because,
Right.
that is definitely where these medications should filter before they filter in a gray market. And I think that's a lot of what was heard that day. But excited for that. But there are a couple more questions. Another one
Sure.
being, in a combo of Cmax and C-Link, would it be better to administer these two in the AM or PM?
Yeah, good question. And typically you'll do them as separate. You would have one and the other. So you typically don't put them together in one ingredient, right? In one bottle. You would typically do them morning and evening. When I've used those in the past, I've done them. I start them off in the morning and see how they respond. See, wow, are you less anxious? Do you feel better? And then if they go, yeah, I'm pretty good throughout the day, but in the evening I start ramping back up and now I can't sleep. Well, that's when you want to go to a second dose. And I think you start with one or the other. Like Stellank for me, a little more specific to, anxiousness, sleep, whereas, CMAX, a little more dopaminergic and, GABAergic. So focus, but calm, protecting the brain, BDNF activation. But I'd start with one or the other, and then you could alternate the doses. If you were going to alternate those doses, I would recommend CMAX in the day, Selank at night. If you're
Okay.
going to do them both in the same day, if you're going to try that clinically, you wanted to do that, I would do CMAX in the morning, Selank at night.
Great. I'm sure that perspective was helpful. Is there a recommended length of use of MOTS-C? It is recommended to cycle it. Is there a projected weight loss percentage? I think everybody's been given so much data through pharma and different medical medications that
Yeah.
they're like, we want to
Well,
know what is the projected amount percentage.
well, I can tell you right now, if you're looking for MOTS-C to perform like a GLP-1, 2, or 3, or an amylin product, it's going to happen, right? So MOTS-C was approved. What basically MOTS-C was put up for weight loss. So as it relates to you have your mitochondria become inefficient because maybe you're a pre-diabetic and now you're only making 2 packets of energy. You're not burning fat. You're going to see some weight changes. There aren't any big formal data that's going to say, oh, you're going to lose 10 or 15% of your body in fat mass. The value of MOTS-C is in, for example, people that use GLP-1s, we know that it improves their mitochondrial density. All right. So I need to improve the way the mitochondria are firing. Are my mitochondria functioning? And that's the same whether it's Parkinson's, diabetes, obesity, heart disease, people with heart failure, they have mitochondrial, you know, mitochondrial mitopathies of the, in their left ventricle. I mean, all that stuff is occurring. So don't look at MOTS-C as, oh, this is my primary weight loss agent. I would say if you're going to do that, you would combine that with something else. Maybe AOD 9604, which will be the next peptide that's kind of coming up, which works really well for weight loss if you do not want to use a GLP-1.
Okay,
And then,
great.
how long do you use it? Once again, why, the whole purpose of compounding is for individuation, right? So it's going to be different. So you're going to have people that, so if I'm telling the typical person that that I'd be working with, yeah, 4 to 6 weeks on, maybe up to 3 months on, 2 weeks off, take a couple breaks. You don't want to push your mitochondria continually, right? You think about that. It's like asking a racehorse to run at 100 miles an hour all the time. That's what you're doing when you're asking your mitochondria to overperform and utilize a peptide all the time. That's why you take a break. So if it's because someone has Parkinson's and they have a significant deficiency in mitochondrial firing or a long hauler, a COVID long hauler, well, then you probably need to use it more frequently for them. They may not be able to take a break until you get them over that threshold of whatever illness that they have. COVID long haul is one example. I mean, Parkinson's would be if they were able to reverse it because it was due to some sort of toxicity, and it was a Parkinson-like syndrome, right? Then you could think about it. But those are people where you may be using it because of their chronic condition more frequently versus on a longevity cycle. Oh, I want to do this because I want to make my mitochondria turbocharged, right? That's where you got to make sure you're taking breaks.
Yes, important. Okay, so another question. It looks like some back to BPC. Have you ever heard of aerializing BPC for voice box injury or inflammation? And where could
Wow.
you source a nasal spray?
Well, uh, I would source it at a compounding pharmacy for one. And I would say aerosolizing it, I've not heard of, but sure is interesting. I think that would be a legitimate to attempt to do that. That'd be great. Yeah, makes sense. You're just going to calm the mucosal barrier, right? When you have I remember when I developed a vocal cord polyp once because speak so darn much. Um, I would have loved to have had something that would have kind of repaired the surgical spot, helped the mucosal barrier to come back. I think that's it's a good thought actually.
Yeah, awesome. Okay, and then another question. When will the third edition of your peptide handbook be available? I'm like,
It'll probably come out for Las Vegas. I'll probably bring it out for that and be able to sign that there. I mean, edition two is pretty dang thorough. I mean, it's not like it's old information. I'm just adding more peptides to each edition. But the second edition, which you can get at Amazon, is quite good. I've had a lot of compliments from practitioners because it's practical, but it gives you the information you need, the level of evidence, what you should look out for, any contraindications, all the typical things that we want, when we're looking at prescribing something.
great. And then last question is around stacking peptide. I know this is
Uh,
probably an often conversation, like which ones play nice together. I know you gave a lot of information about adverse events or contraindications, but talk to us about what evidence there is around maybe like TB 500, BPC 157. Is it superior to, using them standalone? I know some you just mentioned should be separated. We want to hear from you.
yeah. So I'm going to name any three drugs that we give all the time and see how much evidence we have of them. So there really isn't a lot of uh, solid evidence. So just like if I said NSAIDs, birth control pills, and thyroid medication,
Yeah.
nobody's got a study on that, right? So you're not going to see a lot of there's no big clinical repository of information regarding it. Here's what I'd say. One is people that are I have people come in all the time doing 10 peptides. It's like they're being pincushions. What? Well, are you getting better? What do your labs say? How do you feel? Are you just doing this because it's cool and you saw it on social media? You know, So typically, if you look at mechanisms of actions of peptides, they're very focused. KPV, TNF alpha, TV500, acting on cytokines in the connective tissue. BPC, stimulating gastric mucosal tissue, helping with metalloproteinases. You see these things used together. And so clinically, I would say the evidence is good that BPC and KP and TV500 work great together. But is there some study I can point to and see it shows superiority over one or the other? No. Now, that being said, can you put all these in one bottle? Everybody's doing the Wolverine stack or the Glow stacks, or I don't know. I think that how we're going to know that when compounding pharmacies are doing stability studies on them, and they're showing that they're stable and they're showing that they hold up and they don't they don't decay, within the before use state, and then you're going to feel comfortable that you can put them together in the same bottle. But I mean, right now, there's none of that stuff is there. I mean, I'm not a big fan of like ipamorelin, CJC, ipamorelin, and like sermorelin, or another compound. There's some of them that have been vetted and we know they're stable, but that's the work of compounding pharmacy, right? Find out if it's going to be stable, and then you can go from there. Should you stack? Yeah, I think people could do more than one peptide at a time. Should you do 20 at a time? I hope not, right? I think, I just think that, but I have to be honest with you. I literally have people come in that will have an Excel spreadsheet and they're on 6, 7, 10 peptides because the biggest problem that they don't understand is they think it's turning this switch on, and then it's turning that switch on. And, our body's a little more complex than that. So, we have to look at labs, look at symptoms, where are you at, and then which peptides make the most sense in a plan that will be progressing to different peptides. And if you're using peptides for longevity, you're going to use them with some seasonality, right? You may rotate based on what the needs are, what your goals are.
Yeah, that's a really great perspective, Jim. And I would say that is probably exactly why these peptides are being funneled through the use in compound pharmacies, to be able to do those solubility studies and see if they hold up over time, and vetting a correct one. And it is the work we do. And every day I'm in our task management software, seeing where they stand in testing and making sure like our R&D teams making sure methodologies stand. So hey, Jim, we have been so thrilled with the time we got to spend with you today. You gave us amazing perspective, a really thorough review of these peptides. I know our providers probably feel more informed and confident about these medications and what's to come with them. So we really appreciate all that you shared with us today, and thank you so much.
Oh, it's my pleasure. I hope your providers lean into doing peptides because they're going to change their practice. It's going to help them a bunch. I'm positive. So,
Thank you so much.
all right.
All
See you
right.
guys. Bye bye.
Bye.